So, very good morning to all of you, and thank you all for joining this webinar. And thank you, Sun Pharma, for organizing this great event. So, today we'll be talking about a child with asthma who doesn't seem to respond. Now, this clinical situation is not rare. So, a child with parents might just walk and into your clinic and saying that my child is not doing well. Doctor, help me, help my child. And the child seems to be on all drugs. So the child seems to be on some inhaled steroids, some long-acting beta agonists, some deriphyllin-like salts, some montediocast, some nebulization is going on, and off and on the child is taking steroids as well. So the clinical situation is really confusing, and this is the situation of the doctor who's sitting across, and he actually doesn't clearly knows what is to be done. So today we will talk about one such child who presented to us. So with that child, we'll just see how a child would present and how do you tease out the history, the clinical examination, and go on to a diagnosis and a certain why this child is not improving. What is to be done regarding this child? And then we'll go on to some cases which will help us to understand that all that wheezes may not be asthma. And then at the end we'll summarize a bit of literature and then end with some conclusions. So let's go across with this child who presented to us last year. So this is Miss Rim Jim, who is 9 years old girl and who has been referred to us for her non-improvement in asthma symptoms. So if we look at the clinical history in short, she's a 9 years old girl. She was well till approximately 3 years of age. And then she started having episodes of cough, which usually started after a cold and which went to the chest. Now, initially, these episodes were 3 or 4 times a year. The child used to improve with nebulization and some oral medicines. But now, since 2017, so for the past 2 years, the number of episodes have been increasing. So instead of 3 or 4 episodes a year, the child started having increased number of episodes, so 6 to 8 episodes a year. And correctly, the child was started on inhaled steroids with budesonide 400 microgram total dose. Now, since January, the number of episodes have increased further. So 3 or 4 episodes since January, which have been requiring oral steroids. So despite this child being on inhaled steroids, this child doesn't seem to be doing well. And when you examine this child, the child is otherwise well, the heart rates are normal, the respiratory rates are normal, and the child is wheezy. So what is to be done in this situation? Right? So this is not uncommon, a child presenting to you with with a history which is suggestive of possibly an asthma, and the child is on a lot of drugs, but the child doesn't seem to respond. So what are we going to do about it? Right. So let's go across and evaluate this child in a bit of detail. So what I would like to know further. So I would like to describe one episode in detail. So I would definitely like to tell them that is the cough productive or wet cough, or is it a dry cough? Because sometimes you can be dealing with a bronchiectasis. How does it begin with? Is it always virus-induced episodes, or even without a viral infection, the child starts to wheeze and cough? How many days the episode usually lasts, and what medicines are required to abort the episode? So once we ask the mother, the episodes are usually dry, but sometimes they are wet during the course. Initially, it starts with a cold, but now even without cold, she has episodes. Right? They used to last for 5 to 7 days, but now they're getting prolonged. So they might be lasting for 10 to 15 days. And these things are all important because if you're dealing with asthma episodes, then prolonged cough is something which makes you feel that this child possibly has asthma. And the child requires nebulization with steroid syrups as well. So that tells you the gravity of situations. Now, what else would I like to know? So I would like to know the information on severity of the episodes. right? So how many times the child has been required to go to the emergency in the hospital? Has the child ever been admitted in the hospital? Has she ever been admitted to the PICU? So when we ask the mother, she has required 1 or 2 ER visits in a year. She gets breathless and has to be taken to the emergency in the night. She has been admitted once 3 years back, that was in the ward. But last year she had a bad episode and she required an ICU admission. Now, we would like to know about seasonal variation because that is again typical of bronchial asthma. And we would also like to know about what's happening towards severity. Is it increasing? Is it the same? Or is it becoming better? That will help us to decide the treatment which we want. So, yes, there was seasonal. She used to be better in the peak summer and the winters, but now, irrespective of season, Rimjim has episodes, and the mother feels that for the past 1.5 years, the severity is getting up. So, what else we would like to know? We would now like to see that what's happening to Rimjim in the past few months, right? So we have got a broad clinical picture that we know that yes, she is possibly an asthma. She started at 3 years of age. For the past 6 years, she has been having symptoms, often on ER visits, one ICU admission, one ward admission. But what has been happening to her daily life? So, how many days a week on average she gets symptoms of cough and breathlessness? How many nights she's not doing well? And does the asthma interfere with her exercise? Once we deal with these questions, we found out that she has daily symptoms now. The cough persists and increases with exercise. She used to play basketball, but she gets breathless now and she has stopped that. And twice a week, she has nighttime symptoms as well. So that tells us that she has possibly an asthma, and this asthma is definitely poorly controlled. So as you know that there are two domains of asthma control. One is the current impairment and the other is the domain of risk. So she has definitely a lot of impairment in the current functioning. Right. Now, in addition to the asthma symptoms, we would like to know about the comorbid conditions which the child might be having in association with the asthma. So we would like to know about the recurrent sneezing, nasal block, blocked nose, and itchy nose, and how many hours per day the symptoms are troublesome. And does it affect the daily activity? So, yes, she's having nasal symptoms for the past 4 to 6 months, almost daily symptoms, and 3 to 4 hours a day, she's not feeling as good. She's sneezing, especially in the morning. She's having a blocked nose, but not a runny nose. And she also complains of something going down the throat and increasing her cough. And that is possibly suggestive of a postnasal drip. We also like to know about the mouth breathing, which tells us about the adenoids, any snoring, difficulty in sleeping. So we are looking at sleep apneas and any problems with speech and hearings, which can be associated with an adenoid hypertrophy, which we are trying to look at. So she had none of these problems. You would also like to know about what triggers her asthma, when anyone smokes in the family, any irritants present in the environment like deos, perfumes, talcs. Are they using any smokes in the family, coils, any irritants, and does she play in a dusty environment? So yes, father occasionally smokes. She is fond of deos, perfumes, but they're not sure about the school environment. And then we would definitely like to know about the medicines which she is using and how is she using. So a very important question is inhalers. So when were they started? Who gives it? How often do you think the doses are missed? Are you using a spacer in association with your inhaler? How do you take it? And at the end, do you know what are the benefits of inhalational therapy? So she was started on inhalers last year when she got into the PICU. She is usually supervised by the mother, but now she feels that she's well trained and Rimjim is 9 years and she can take the inhalers herself. How many doses are missed? Well, doctor, I'm not sure. She might be missing a few. but the mother is not supervising, so she's not very sure. And can't she use a inhaler without a spacer, doctor? I have seen it in a lot of television serials and films. She's quite grown up. What is the use of this spacer? And when we asked her that, do you know about the benefits of inhalational therapy? Well, doctor, we were asked to use inhalers. We were told they're good, but and she pauses and says that, they can be addictive. That they have steroids. And my doctor who started said that they have to be taken at least for a year or even longer. And doctor, do you think it cures her asthma? So once you dig deeper into the history, you realize that there are lots of things going on which you may not have realized, which are on. So although she has been started on inhalers, there are a lot of apprehensions in the mind of parents, right? And that can be one of the reasons why this child doesn't seem to improve. So let's go ahead and see what's happening to Rimjim. So when you examine her, her weight is fine, she's well built, her height is okay. She has no other significant findings, no atopic features. Her chest seems to be normal in shape, and she has a bilateral polyphonic wheezing. And you examine the other systems in detail. So the cardiovascular, the abdomen, and the CNS seems to be within normal limits. Now, it's a part of our examination that we would always ask parents to show how you are taking your inhalers. And let's see, can we improve it? We might be able to do that. So I can take it well, doctor. There are no issues. I've been trained well. So that's the usual question the parents. This is the usual answer which parents will give you. But we are also a bit adamant in all these things. So we always tell them, okay, let's see. We might be able to improve it. And once she was taking her inhaler, the canister was empty. She did not exhale well. She did not inhale well once she had actuated the inhaler, and she did not hold her breath well. So we realized that there are lots of problems with the technique. That might be a reason why Rimjim is not improving. So let's summarize Rimjim here before we go on. So what we are thinking about is that what is the possible diagnosis? Are we all sure it is asthma and it is nothing else? So do we have a possible differential diagnosis? How would you classify her control? Do you think this is partially controlled, well controlled, or poorly controlled? Does she have any comorbid conditions? And has the family received adequate asthma education? So, do they know about the disease? Do they know about diagnosis? Do they know about the dose of the drug to be given, how it is to be given, what are the delivery issues, and do they know about trigger and allergen avoidance? So we went ahead and investigated Rimjim. And the most important investigation in such scenarios would be to do a lung function test. And this is a typical spirometry trace which you would find in a child with asthma. Now, if you look at this graph carefully, then you can find two curves, the blue one and the red one. So the blue one is the pre-bronchodilator curve, and the red one is the post-bronchodilator curve after we have given 400 micrograms of salbutamol. So if you look at this graph, then this graph appears to be slightly smaller in size. And if you look at the shape of the curve, then this part of the curve appears to be more of scooped. So it shows a lot of scooping, which tells us that this curve has obstruction. And the post-bronchodilator curve is much better in shape and size, and this scooping has gone. And if we look at the values, then look at the FEV1s and the FVCs, and you can see that the FEV1 by FVCs are low. The FEV1 by FVC ratios are reduced, suggesting of obstruction. And once you repeat them after giving a bronchodilator, then you can find a significant reversibility in the FEV1s. So it suggests a reversible airflow obstruction, and that is consistent with the diagnosis of asthma in this particular child. So finally, With regard to Rimjim, we can conclude that she has an asthma, there's no doubt about it. We have a lung function which shows obstruction, which shows reversibility. She has comorbid conditions in the form of allergic rhinosinusitis. And let's identify the reasons why she is not well. So, reasons for poor control could be poor adherence, improper technique, allergens which have not been taken care of, comorbid conditions like allergic rhinosinusitis, and she might be getting an inadequate drug doses, and we might consider doing a step up of treatment. So the family was given education regarding the diagnosis of asthma, the need for inhalational therapy, and the devices which are available. We reinforced the need for adherence to medicines. We demonstrated and checked the technique and did a trigger avoidance. So we added intranasal steroids for the comorbid allergic rhinitis, and at this moment we added LABA to the inhaled corticosteroids to make her better. And in addition, all children with asthma, especially if they have ER visits or if they have admissions, they would need an asthma action plan. So ideally, all patients would need, and this asthma action plan has a green zone, yellow zone, and has a red zone. The green zone is doing well, and they need to continue their medicines regularly, even if they are well. The yellow zone is when the asthma is getting a bit worse, so what they are going to do about it. And the red zone is a medical alert. Then what are they going to do about it? Give a dose of prednisolone, give bronchodilator every 20 minutes for 3 times, and rush to a hospital. And these are asthma actions plan which are available everywhere, and this is something which we use in our clinic and in our hospital. So once you have decided on what step of treatment you are going to put the child on, you can step up or step down. And this is the latest GINA table for 6 to 11 years of age children. So you have step 1 to step 5. So step 1 could be either no treatment or SOS, short-acting beta agonist, but sometimes people advocate that low-dose inhaled steroid should be added. Step 2 is daily low-dose inhaled corticosteroids. The alternate options, but not as good options, could be montelukast. Step 3 is low-dose steroids with LABA or medium-dose steroids. Step 4 would be a medium-dose steroid with LABA and might need an expert advice. And step 5 is a poorly controlled child on these steps of treatment, which requires expert opinion, and you might be dealing with a severe asthma. So these are the steps which we have talked about. Now, for older children more than 12 years of age, the steps are a bit similar. The only difference is that at step 1, we have good data to suggest that SOS ICS formoterol can be used, or low-dose ICS with SABA can be used. So that is the new GINA change which has happened, and the rest of the steps remain nearly the same. Now, what happened to Rimjim? So we were looking at improvement in symptoms, breakthrough symptoms, rescue SABA, sleep disturbance, school absenteeism, what happened to her physical activity, the satisfaction of the family regarding treatment, the compliance, and the technique. So she had good improvement in her symptoms. There were no breakthrough symptoms. She did not require SABA. There was no sleep disturbance. She was going to school properly. She could play. And they were quite satisfied, taking their treatment properly, and the technique was good. So after 3 months, she was shifted to plain corticosteroids. So if you remember, we had added LABA. So we had stepped down after 3 months. And then after 6 months, she was shifted to low-dose inhaled corticosteroids, so which was again a step down from the medium dose which she was on. And she was also given an asthma action plan. Now, just a small word regarding children who are under 5. So we know that you can have a mixed bag here. You can have few children who have asthma, few children who do not have asthma. So Gina has given a very easy symptom-based approach, which tells you about the probability of a particular child having asthma. So on your left, you have symptoms like short duration URI followed by a wheeze, a few episodes in a year, like 2 or 3 in a year, and no symptoms between episodes. So very few of them will have asthma. Now, as the duration of episodes increases more than 10 days for each episode, more than 3 episodes in a year, severe episodes, and even in between episodes, the child keeps having symptoms, then the chances of asthma increases and some will have asthma. Now, as you go on to the right side, as you can see, the symptoms are longer. The number of episodes are more than 3 a year. In between episodes, the child still has cough, wheeze, heavy breathing. And in addition, they have allergen sensitization seen by a skin prick test, atopic dermatitis, food allergy, or family history of asthma. So they have given a lot of weightage to the family history and an atopic background for a particular child. And in such situations, most children will have asthma. You can do a lung function in young children as well. So this is something which is now used for long times and available even in India. So this is an equipment which is called as an impulse oscillometer. So this is a loudspeaker which produces sound waves. These go across here to the pneumotac, and the child is holding on to this mouthpiece and breathing. And the breathing of this child gets superimposed on the sound waves, and in totality, it is picked up with the pneumotac, and you get your results. So it will give you something different than the traditional spirometries which we are looking at. So it gives you resistance and it gives you reactance. And there would be a lot of children where we would find that the spirometries are normal. So for example, this is a 6 years old child who had suspected asthma, frequent symptoms, required nebulization, but spirometries are normal. But when we investigated this child further, we found that the impulse oscillometries shows significant obstruction and reversibility. So these are the R5 or the resistance at 5 hertz, which is significantly increased. The normal value is around 100. And once you give bronchodilators to this child, it improves significantly. So there's a 42% change in the R5 values post bronchodilators, which tells us that this child definitely has obstruction and reversibility, even when the child had a normal spirometry. So it is actually something what is known as or described as small airway dysfunction in children with asthma. Now, children have, or younger children have, again, a step ladder from GINA. So it goes from step 1, which is an infrequent wheezer and no interval symptoms. Only SOS treatment is required. Now, as you go on to step 2, so the symptom pattern is more consistent with asthma. So if you remember the table which I had shown, symptoms is in the middle one or the right side, and asthma symptom doesn't seem to be well controlled, or the child does not fall into a, a symptom pattern which is consistent with asthma, but the child keeps on having frequent episodes of wheeze. So child has one episode in September, then October, then November, and December. So even if this child appears to be like a Woolery, this child deserves prophylaxis to improve the quality of life. And hence, this child should be on step 2, which is daily low dose inhaled corticosteroids. Now, if this child doesn't seem to be doing well and you do not have any alternate differential diagnosis, then you might switch on to step 3, which is doubling the low dose inhaled corticosteroids. If you have started something like 100 microgram of budesonide air, you can shift this child to 200 microgram of budesonide. And even if this child is still not improving, then you go on to the step 4, which requires an expert opinion to rule out alternate differential diagnosis and see why this child is not getting better. Now, once you have done all these things and you have followed up Rimjim for a longer period of time, for approximately 6 months to a year, you'll be able to classify her severity. So now the classification of severity is not based on the current symptoms, rather, they are based on the amount of medicine which is needed to give them a good control. So, if a child needs low dose inhaled corticosteroids for a good control, then despite the initial frequency or severity of symptoms, the child would be classified as mild. So, as you can see, Rimjim had very bad symptoms initially, but finally, Rimjim could go on to low dose inhaled corticosteroids and was remaining well. So, even if the presentation tells us that she might need a higher dose, she has settled down at a low dose inhaled corticosteroid, and we would still label it as a mild form of persistent asthma. Now, let's come to the core topic, that when do you label a child as problematic severe asthma? So, any school age child who requires at least 800 microgram of inhaled corticosteroids, which is budesonide equivalent, and has undergone a trial of at least two of the three additional controllers. So 800 micrograms of inhaled corticosteroids. And in addition, the child requires or has undergone a trial of two or three controllers in addition. So that is LABA, so that's your formoterol or salmeterol, has, has got a trial with LTRAs, that is your montelukast, and oral theophylline, and still has symptoms, right? And these symptoms would fall in either of these categories. So, persistent chronic symptoms with a poor quality of life. So, daily cough, daily wheeze, daily breathlessness. Acute severe exacerbations with or without associated interval symptoms. So, you've given high moderate dose inhaled corticosteroid plus LABA plus montelukast, and still the child gets 4 or 5 exacerbations a year. In one of these exacerbations, the child is admitted and might get admitted to an ICU. So this child is not doing well. Then persistent airflow obstruction following a steroid trial. So you've given steroids, the child responds, but on the lung function, the child shows a persistent obstruction. Or the child needs alternate daily doses of steroids or alternate days of steroids. So these are the scenarios when you would consider this particular child as a problematic severe asthma. Now, this problematic severe asthma includes 4 types of children, right? So, one could be it is actually not an asthma. So, you're not dealing with asthma, but an alternate differential diagnosis, and we are going to talk about it in the next slides. So, not asthma at all. The other could be that the child has an asthma plus, which means there are additional comorbid conditions which is not letting the asthma settle down, right? As Rimjim had. The third could be that it is difficult to treat. Why it is difficult to treat? Because she is not getting proper treatment, right? And the fourth, which is the most uncommon of all these, would be a true therapy resistant asthma. And even this term is changing because therapy resistant asthma, now you have a lot of therapies for resistant asthma. So even this term is now going to fade off. And usually, you have a combination of an asthma plus and a difficult to treat situation because of the compliance, adherence, and the technique related issues. That is what Rimjim had. Now, let's go on to what we were talking on here, that not asthma at all. So, you have a list of differential diagnosis or atypical wheezers or mimickers, which can present with similar symptoms, but they are actually not asthma. So they could be things like infections, which can be recurrent LRTIs, bacterial bronchitis, suppurative lung disease, and bronchiectasis. So this is one group of conditions which can present with these symptoms. You can have symptoms of tuberculosis, you can have chronic rhinitis, sinusitis, adenoid hypertrophy, and a bronchiolitis obliterans. So these are conditions which can present with wheeze, but they're actually not asthma. Then you can have congenital problems like tracheomalacia, bronchomalacia. You can have things like cystic fibrosis, bronchopulmonary dysplasia, ciliary dyskinesias. And you can have things like immune deficiency, which can present like this. Then airway compressions because of vascular or non-vascular airway compressions. Each type of tracheoesophageal fistula. So congenital problems are definitely on, and especially in young children, they are quite important. And then we can have mechanical problems like gastroesophageal reflux disease or GERD and foreign body aspiration. And believe me, we do see all of these things in clinical practice. So each and every diagnosis we have seen multiple times. So be careful about atypical wheezers or mimickers. We do understand that it is a long list of differential diagnoses and it's not easy to take them on, right? But at least we should know how to, pick up that odd man out of those 50 patients which you might be seeing a day. So I'll just give you two examples showing two clinical cases. So this is an old case of ours, 12 years old boy who presented to the ENT department. Why ENT department? Because this child had a chronic nasal obstruction and nasal discharge for the past 3 or 4 years. On examination, had a nasal turbinate hypertrophy with a nasal discharge. So the ENTs got a CT, and the CT was showing a lot of sinusitis. So pansinusitis involving the maxillary sinuses and the other sinuses as well. So it was a pansinusitis, and the child doesn't seem to be improving. So they had planned this child for a functional endoscopic sinus surgery. So how did we get into the picture? So when this child went to anesthesia for a pre-anesthetic checkup, they found this child has been wheezing. So this child was referred to pediatrics. So once we reviewed the history, there was a persistent nasal discharge, there was nasal obstruction, and there was a chronic cough and possibly a chronic wet cough. Now, this child did not have any severe exacerbations, aeroallergen sensitization, atopic dermatitis, any GRD symptoms, and no family history of atopy or asthma. So similar ENT findings, nothing else we could find. There was a bilateral polyphonic wheezing. So we also kept the diagnosis as asthma with rhinosinusitis. But this child wasn't improving with the asthma treatment which we had given. But why? So we had done a lung function. Again, you can see lung function shows a mild obstruction, scooping of the curve, low FEV1 by FVC values, but no significant reversibility. That's a bit fishy, but we thought let's treat it as asthma and let's see. And this child has 3 X-rays. So have a good look at these X-rays and what do you think these X-rays are telling us? So a bit of hyperinflation in all these X-rays. They appear slightly more black. And this diaphragm seems to be flattened on both sides. Anything else? Well, we missed a lot of things on this X-ray, and that is what we had missed. So if you look at these X-rays carefully, then the marker was actually on the wrong side. It should be on the right side. So this child actually had dextrocardia, which we had missed. And dextrocardia with all these symptoms, or a situs inversus with all these symptoms, point towards the diagnosis of a primary ciliary dyskinesia or Cutagner syndrome. So this was an asthma mimicker which we had seen. So be careful about things. They do come our way. Now, you can have situations like this as well. So this is a young child who is around 6 months of age, and this child has been having noisy breathing for the past six months. So since birth, the child has not been well and has been on nebulization on most days of the month, but no response, no hospital admissions. Something different going on. Noisy breathing since birth, no response to nebulization. So let's see this video, and I hope I can play it for you. Okay. So look at the respiratory image carefully. Okay, so this child has a noisy breathing, and this is possibly since birth. So we are possibly dealing with some congenital issue which has been masquerading as asthma. And if you look at this child carefully, then otherwise the child is well, but the child has some expiratory noise. Fine. So noisy breathing could be in the form of a stridor, which is something like. So it is not like that. It is an expiratory sound like this. So this is a typical expiratory wheezing or a monophonic wheezing which was heard. So we were possibly dealing with some tracheal issue. So we went ahead and we thought that this child possibly requires a bronchoscopy to look at tracheal compressions. And I'll just play this video for you. So this is the flexible bronchoscopy which we did. And as you can see, this is the anterior tracheal wall, this is the posterior tracheal wall, and in between you find that the trachea is actually collapsing. So hardly any space can be seen here. And as I go down, you'll be able to see the carina and the trachea. So you can see the posterior tracheal wall, the anterior tracheal wall is almost approximating, and you can't find any space here. Now, as we are going down towards the carina, you'll be able to visualize the bronchus. So you can see the left main bronchus here. You can see a left main bronchus here, but you still can't see a right main bronchus because of the tracheal compression, which is more on the right side. And as I go down, you can now see the right main bronchus and the left main bronchus. So right main bronchus, well seen, no compression here. Right intermediate bronchus and the right upper lobe bronchus. And as I turn to the left side, the left bronchus also appears to be normal. So it is a tracheal compression which is not varying with the respiration, which is not dynamic. What are the causes? So the usual cause in this age group is a vascular airway compression. So we did a CT angiography, and what we find here is that this is the right aortic arch and this is the left aortic arch. So it is a double aortic arch, and in between the two arches you have the trachea and the esophagus which are compressed. And most of these children will have some symptoms associated, some esophageal symptoms associated. So usually they would have some amount of dysphagia in between. So be careful about congenital lesions. Right, so let's go on and see the theoretical background regarding these. So if you have a child who presents to you with a difficult asthma, the step one is to confirm a diagnosis and look at differential diagnosis, which we have just talked about. Then you look at the contributing factors to symptoms, exacerbation, and poor quality of life. So you have to go back and drill down the whole history and examination again and again and see what we are missing at. And then you try to optimize treatment. You optimize the technique, deal adherent issues, treat the comorbid conditions, and you might need to step up treatment as we had done for Remgen. Right? So once the child presents with this, you have to go from step 1 to step 3. Now, once you have done this, you review the child in your clinic for the next 3 to 6 months and assess the response. And After doing all this, if the child is still not well, then you can label this child as a severe asthma or a therapy resistant asthma. So, any child who presents to you today cannot be labeled as a therapy resistant asthma or a severe asthma. You have to follow this child up for the next few months. Look at all the things which we have talked about in the presentation today. And after 3 to 6 months of treatment, you would be in a position to clearly say whether this child responds to the therapy or not, despite these adequate steps. So, if this child is not responding now you have to phenotype this child to decide treatment. So, we need an FeNO or an exhaled nitric oxide, blood and sputum eosinophils, skin prick test, or an immunocap to look at what's going on. Is it an IgE mediated asthma or not? Now, as you go on and assess this child, we have to look at type 2 inflammation or the eosinophilic inflammation. So, how do you judge that? So, blood eosinophil is one marker. You can have an FeNO of more than 20 or sputum eosinophils of more than 2%, or asthma you find is clinically allergen driven. So, these are the indicators which tells you that it is a type 2 inflammation or an eosinophilic type of asthma which you are dealing with. So, now you can divide your children with severe asthma into two groups, eosinophilic and non-eosinophilic. So even at this step, or what is known as a step 6A, we are still going to optimize treatment. Look at adherence again, because there would be a lot of patients who, despite being severe, are not adhering to treatment, and you can use smart inhalers, and one of the devices is now available even in India. So these smart inhalers can trace each and every dose which has been taken by the patient in a digital form. Try high dose inhaled corticosteroid for 3 to 6 months. Consider using tiotropium, and we are just going to talk about tiotropium in the next slide. Consider a possibility of GERD, bronchopulmonary aspergillosis, rhinosinusitis, and treat an atopic dermatitis if it is there. Now, in non-eosinophilic patients, the rest of the things remain the same. You might try macrolides. And if the child is actually behaving like non-eosinophilic, then you should be more digging into the differential diagnosis and considering a CT chest, a bronchoscopy, induced sputum, because you might be dealing with a bronchiectasis, and hence this child is not showing the correct phenotype. Now, tiotropium is basically an anticholinergic drug which can be used for children more than 6 years of age and adults with poorly controlled asthma, and is currently an option for step 4 and step 5 of GINA. And there have been large randomized controlled trial with childhood difficult to treat asthma, and it has been a good add-on. It improves lung function, it decreases the risk of exacerbation and slows the worsening of disease. And we have some amount of data in 1 to 5 years as well, but in less than 6 years of age, it is still an off-label use. How does tiotropium act? So the mechanism of action appears to be complex, but it has to deal with modulation of bronchomotor tone, inhibition of smooth muscle remodeling, inhibition of Th2 cytokine release, inhibition of chemotactic mediators, eosinophilic recruitment, modulation of goblet cells, and increase in cough threshold. So you can read about tiotropium if you feel you are interested in this. And these are the key trials which are there. I'll not go into details because of the paucity of time. And we have meta-analysis also which are published. So in 2017, we have meta-analysis of tiotropium in school-age children, and we have safety data in children 1 to 5 years as well. So once you're done with 6A, you have classified your child, and still the child doesn't seem to respond. It breaks into two arms. The first would be that, can the family afford, or do they have an access to biological treatments? So that is your omalizumab and rest of the drugs. So that is the anti-IgE, and we'll just going to talk about it. Or that is not available, not possible. Then you can optimize again and see whether you can add on a LABA, tiotropium or put this child on low dose oral corticosteroids on alternate days to maintain this child. Now, the step 6B is basically for biologicals. So, what do we have which is available to us? So, omalizumab has been there for the past many years. You need to have a perennial allergen sensitization before you embark on omalizumab. It has to have that IgE range and the weight range and a specified number of exacerbation in the last year. Only then omalizumab can be used. Then you have something new which is available, which is known as an anti-IL-5 antagonist, which is known as mepolizumab, which is now available in India. And European agencies have cleared it for more than 6 years of age. It can be used for eosinophilic asthma. And we also have dupilumab, which is also approved, which is an anti-IL-4R antagonist. Now, again, you can titrate your response. If it's a good response, you reevaluate, gradually reduce the number of drugs, but keep the child still on inhaled corticosteroids. After a period of a few months or a year, try and withdraw the biologicals and maintain this child on low-dose inhaled corticosteroids. For poor response, the options are not very good. Some people are still considering bronchial thermoplasty, but we do not have data as of now, especially for children. So let's conclude with our take-home messages that most children with difficult to treat asthma are due to a combination of faulty basic steps and comorbid conditions, as we have seen. A systematic approach will help to sort out most of these children. Do remember that all that wheezes is not asthma. You still need to look at the differential diagnosis. So, am I sure this child has asthma? Is there nothing else which is going on? And a small number of children have truly a severe asthma and they require an expert opinion. So, when do we need to refer a particular child with asthma to an expert? So, three conditions. If you find a difficulty in confirming the diagnosis, so if you feel it is a suppurative lung disease, cystic fibrosis, ciliary dyskinesias, or tropical pulmonary eosinophilias, but you're not sure about it, you want to further investigation. You have an unclear diagnosis after trial of inhaled corticosteroids. So if given inhaled steroids, but this child doesn't respond, now you feel that you might be dealing with alternate diagnosis. It can be a vocal cord dysfunction or something else which is going on. And then a persistent uncontrolled asthma or frequent exacerbations. So this child doesn't maintain well at step 4 of treatment and you have sorted out rest of the issues like technique, compliance, adherence, and so on. And this child deserves a referral. And this child, if has risk factors for asthma-related deaths, so near fatal asthma or PICU admission or ventilation. So these are the indications of referring a child to an expert. So we end by just by enumerating what services we provide at our hospital and at our clinic. So we're providing bronchoscopies for all ages. We do bronchoscopic extraction of foreign bodies with the flexible scope. Lung functions including oscillometries for young children, sweat chlorides, video fluoroscopic swallows, then allergy testing and sleep studies. So I end here my talk and I would hand over to Dr. Abbas